Welcome to the deep dive. Our mission here is really razor sharp. We take this dense stack of complex medical evidence, the trials, the guidelines, the core physiology,
All of it.
and we just extract the practice-changing insights, the things that you, the clinician, actually need to implement today. We are not interested in reading a textbook aloud.
No,
We're here to challenge, decades of clinical assumptions.
that's absolutely right. And the assumption we're putting squarely on the operating table today is the way we approach diabetes management. I mean, for decades, clinical practice was overwhelmingly glucocentric.
All about the sugar.
Exactly. The dominant model, it was almost a dogma, was that type 2 diabetes primarily harmed the heart by accelerating traditional atherosclerosis.
The CHD equivalent.
The coronary artery disease equivalent, right.
Oh.
The focus was sugar control to, hopefully avert microvascular disaster with this sort of hope that the macrovascular benefits would just follow along eventually.
Okay, so let's unpack this core paradigm shift. We've synthesized material today from the most definitive references, Braunwald's for the physiology, Harrison's for the systems approach,
It's a big one.
and the pragmatic latest clinical guidance from UpToDate 2025, plus that sharp clinical logic we get from AMBOSS. The collective weight of all this evidence, it demands we redefine the disease itself.
Precisely. The central question, and this is the why that has to drive our behavior, to borrow from that scenic lens, is this. How does diabetes fundamentally and independently impair cardiac function?
Separate from the blockages.
Completely separate from the traditional plumbing crisis of coronary blockages.
Yeah.
And then what is the mandatory, the non-negotiable change clinicians have to make in their daily prescribing routine as a result of that pathophysiology?
The answer is profound, isn't it? It requires a complete reframing of the disease. We have to stop viewing diabetes as just a metabolic disorder, characterized by high glucose, and start seeing it as a primary progressive cardiorenal disease. The pharmacologic tools, which we'll get to, they're just a reflection of this new understanding.
Right.
If you're not prescribing based on cardiorenal protection, you are, frankly, practicing obsolete medicine. So let's start by framing the magnitude of the problem. We all sort of cite the numbers, but the sheer scale of the looming global burden, especially when you look at it through that Harrison perspective, is, it's staggering.
It's a global public health crisis. There's no other way to put it. DM is already one of the most common chronic diseases, but the projections are, frankly, terrifying.
What are we looking at?
It's forecast to affect over 700 million adults globally by 2045.
Wow.
Which is roughly 10.9% of the entire adult population. And this isn't just a function of people living longer.
No.
The rising incidence is overwhelmingly driven by the parallel epidemics of obesity, physical inactivity, and the whole metabolic syndrome picture.
And despite all the advancements we've made, new glucose drugs, better statins, the primary tragedy is still the same, isn't it? Cardiovascular disease is still the #1 killer in this population.
It is. It remains the principal contributor to mortality, and that includes the classic macrovascular complications we all learned about: coronary heart disease, stroke, peripheral arterial disease.
That classic triad.
That triad has been the focus for years, but the new inescapable focus, the one that's really driving morbidity and cost, is heart failure, HF.
Right.
The data is just unequivocal. Diabetes associates independently with a staggering 2-fold to 5-fold increased risk for heart failure compared to age-matched people without diabetes.
2 to 5 times. That's a massive risk multiplier.
It's huge.
Yeah.
And HF and diabetes is a key driver of CV morbidity, frequent hospitalizations, and overall mortality. It's why it has become the crucial primary endpoint in every serious modern clinical trial in this space.
This takes us directly to that old idea, that conceptual anchor of DM as a CHD equivalent. Guidelines, from the National Cholesterol Education Program, used to put type 2 DM patients automatically in the highest risk category. They basically treated them like someone who had already had a heart attack.
And this is where we have to introduce a critical evidence-based nuance. For our advanced learners, this is key. While diabetes is, without question, a major independent risk factor for ASCVD.
I'm not debating that.
No. But that blanket CHD equivalent label is imperfect. It's actually misleading about the heterogeneity of the risk.
So what's the data that's challenging that old dogma?
Well, there's a definitive meta-analysis, it's cited in all the new guidelines, that suggested patients with diabetes but no prior MI actually had a 43% lower risk of future CHD events compared with non-diabetic patients who did have a prior MI.
An odds ratio of 0.56.
Exactly.
So it's not a literal one-to-one risk. The risk is high, absolutely, but that blanket label might make you overtreat or at least misstratify a newly diagnosed, otherwise low-risk diabetic patient.
You've hit the nail on the head. The lesson here isn't that DM isn't dangerous. It is profoundly dangerous, but that the risk profile is incredibly heterogeneous. We cannot treat all diabetic patients as one monolithic high-risk group.
It's the clustering of other factors that really sends the risk into the stratosphere.
That's it. It's the synergistic effect. These patients carry a greater burden of hypertension, obesity, dyslipidemia, that classic high triglyceride, low HDL profile.
And then you throw in smoking.
You add in smoking, significant metabolic syndrome features, and perhaps the single most powerful prognosticator of them all, microalbuminuria.
Okay, let's spend a minute on microalbuminuria, or as we should probably call it now, moderately increased albuminuria. Why is this marker, which we classically tie to the kidney, such a powerful independent predictor of cardiovascular death?
This is a classic example of that Harrison systems-based thinking. Microalbuminuria is not just the earliest sign of diabetic nephropathy.
It's not just a kidney problem.
No, it's a direct sign of widespread, pervasive systemic vascular damage. It's a sick endothelium globally. The kidney is simply the first place we can reliably and easily measure it.
So it's a barometer for the health of the entire vascular tree.
Precisely. We know from huge cohort studies, like the LIFE trial, that for every 10-fold increase in the albumin to creatinine ratio, the risk of cardiovascular death, MI, or stroke increased by a substantial 39%.
Wow.
And that's independent of traditional risk factors like BP or LDL. So if you see microalbuminuria on a lab report, you must recognize you are looking at systemic vascular compromise. Your treatment intensity for every single risk factor needs to elevate immediately.
Okay, so we've established that patients with diabetes have this massive independent risk of heart failure. This is the moment we really have to break that old glucocentric mold. If the problem isn't just blocked coronary arteries, what specific non-atherosclerotic damage is diabetes doing to the heart muscle itself?
This is where we have to formally recognize diabetic cardiomyopathy, or DCM, as a true pathological entity.
Independent of CAT.
Completely independent of overt coronary artery disease. This is pure Braunwald pathophysiology. DCM is what explains that disproportionately high rate of heart failure, and particularly HF, with preserved ejection fraction.
HFpEF.
HFpEF that we see in the diabetic population. The damage is happening at the molecular, the cellular, and the interstitial level long before a patient ever develops symptomatic CAD.
So let's dive deep into those mechanisms. Let's start with how the heart's engine starts running inefficiently and, well, toxically.
Okay, the first core mechanism is something called metabolic inflexibility.
Right.
A healthy heart is an omnivore. It loves fatty acids for its baseline energy, but it stays flexible. It can readily switch to glucose when it needs to, under stress, or when insulin is around.
But in diabetes, that flexibility is lost.
It's gone. Chronic insulin resistance and high levels of free fatty acids lead to this chronic, unrelenting upregulation of the genes for fatty acid oxidation.
So the heart becomes this relentless fat-burning engine, but that comes at a really severe cost.
It's a huge cost. This excessive reliance on fat, combined with the fact that the muscle can't take up glucose properly, creates a chronic substrate imbalance. The cell is just flooded with fat, and the sheer volume exceeds what the mitochondria can handle.
And that leads to a buildup of, what, toxic byproducts.
Exactly. Toxic lipid intermediates right inside the heart muscle cells. We see a buildup of triglycerides, diacylglycerol, and maybe the most toxicologically relevant of them all, ceramides.
Let's pause on ceramides. Why are they so bad for the myocyte?
Ceramides are, well, they're signaling molecules, but when they accumulate, they are profoundly toxic. They directly promote insulin resistance at the cellular level, but more critically in the heart, they trigger lipoapoptosis.
Programmed cell death.
Programmed cell death of the heart muscle. They mess with calcium handling, they disrupt mitochondrial function, they induce inflammation. This internal toxicity directly causes contractile dysfunction and stiffness, which is setting the stage for heart failure.
And that cellular toxicity leads us right to the structural breakdown that defines diastolic failure. What is the process that literally stiffens the diabetic heart?
That's the second major mechanism, myocardial fibrosis. And this is driven by advanced glycation end products, or AGs.
AGs.
Chronic hyperglycemia is the engine here. Glucose molecules non-enzymatically react with proteins and lipids, forming these AGEs. These products then accumulate and drive cross-linking within the myocardial extracellular matrix.
So the scaffolding of the heart.
The structural scaffolding around the heart muscle cells, yes.
So are we literally talking about sugar caramelizing the structural proteins like collagen?
That's a great way to think about it. In essence, yes. And this AGE cross-linking significantly increases the passive stiffness of the ventricular wall. The heart just struggles to relax properly.
Which impairs diastolic function.
Fundamentally, it impairs the ability to relax and fill at low pressure, which is the definition of diastolic dysfunction.
And that provides the direct pathophysiologic link between diabetes and the most rapidly growing type of heart failure we see today.
Precisely. This is the third critical link, the high prevalence of HF with preserved ejection fraction, HFpEF. The structural changes we just talked about, the fibrosis, the stiffness, the impaired relaxation, they align perfectly with the pathophysiology of HFpEF.
So diabetes isn't just a risk factor for HFpEF.
It's a primary independent cause. If you have a patient with HFpEF and diabetes, the DCM driven by AGEs and metabolic toxicity is almost certainly the main culprit.
And it's not just the muscle in the matrix. The sources also highlight damage to the small vessels and the nerves.
Yes, we have to look smaller. First, microvascular dysfunction. Diabetes causes these structural and functional abnormalities in the coronary microvasculature, the tiniest vessels that feed the heart muscle. This damage basically limits the heart's ability to recruit reserve capacity.
What does that mean, clinically, a reduced reserve?
It means that during high-stress exercise, fever, even emotional stress, the heart cannot adequately increase its blood supply to meet the oxygen demand.
Even if the big coronary arteries are wide open.
Even if they're completely clean. And this can lead to exertional symptoms, atypical angina, and it contributes directly to myocardial stunning and failure over time.
And then there's the really insidious threat, the one that's often lethal, diabetic autonomic neuropathy. Dan.
This is a critical and I think often overlooked piece of the puzzle. Long-standing diabetes leads to this sympathetic and parasympathetic dysfunction that affects the heart. And DAN is intrinsically linked to silent myocardial ischemia and infarction.
Silent S.
Yes. The afferent nerve fibers that are supposed to transmit cardiac pain signals are damaged.
So the patient has a major coronary event, a big occlusion, and they never get the warning sign of crushing chest pain. They miss that critical window for intervention.
Exactly. Histological studies confirm this. The absence of typical chest pain delays presentation to the ER, it delays reperfusion, and as a result, it significantly increases both morbidity and mortality. It's a catastrophic failure of the body's alarm system. And this whole complex pathology proves that diabetes isn't just accelerating atherosclerosis, it is an independent disease engine creating heart failure through multiple specific mechanisms.
Which means our treatment priorities have to shut in completely. We can't just chase the HbA1c anymore. Okay, this is the moment. This is where the basic science and the clinical trial evidence just slam together and force an immediate, radical practice change. And if we look at this through the Alex Hormozi lens, the value proposition of these new drug classes is so massive, so irresistible.
It is.
That they have to be incorporated immediately. Glucose-lowering drugs are now cardiovascular protection drugs, period.
The cardiovascular outcome trials, the CVOTs, they irrevocably changed the landscape. The old goal was glycemic control first. The new goal has to be cardiorenal risk mitigation first. It's a non-negotiable step change in clinical culture.
Let's start with the ages that completely shifted how we treat heart failure and diabetes. The SGLT2 inhibitors, pemphigliflozin, canagliflozin, dapagliflozin.
Their results were just profound and consistent. SGLT2 inhibitors dramatically and reliably reduce the composite endpoint of hospitalization for heart failure, HHF, and progression of renal disease.
And this was across all the major trials.
Every single one.
Yeah.
MPREG, Canvas, Declare, Virtus. You saw this benefit again and again, and often surprisingly early in the treatment course.
What is the pooled clinical magnitude of that effect? What's the number clinicians need to have in their head?
A comprehensive meta-analysis shows a pooled estimate for HHF reduction of a hazard ratio of 0.68.
Yeah.
That's a striking 32% relative risk reduction in heart failure hospitalization.
For a disease where HF is a primary driver of cost, poor quality of life, and mortality, that is a massive effect.
It's clinically equivalent to aspirin post-MI or high-intensity statins. It's that powerful.
And what makes this so revolutionary is how broadly it applies. This isn't just for the sickest patients, is it?
No, and that's the strongest argument for why they are now foundational therapy. The HHF benefit applies consistently to patients with established ASCVD and to patients without established ASCVD.
Primary and secondary prevention.
Exactly. And, crucially, The benefit is seen in patients with and without prior heart failure at baseline. The consistency of this signal suggests the mechanism is fundamental and protective against the underlying diabetic cardiomyopathy we were just discussing.
So let's talk about that mechanism, because the benefit is largely independent of how much the A1C drops, right?
That's the essential conceptual break from the past.
Yeah.
It's largely independent of glycemic control. The leading theories are multifaceted. First, they cause a mild osmotic diuresis, a gentle volume reduction.
But it's a favorable fluid management.
It's favorable because it happens without the adverse neurohumoral activation, the increased renin or aldosterone that we see with loop diuretics.
Okay, what else?
Second, they have favorable effects on cardiac energetics. By increasing the utilization of ketones, they might be giving the failing heart a more efficient fuel source.
A superfuel.
Sort of, yeah. Potentially mitigating that metabolic inflexibility. And third, there's growing evidence of direct effects, reducing inflammation, mitigating oxidative stress, maybe even directly affecting mitochondrial ion channels. It seems to hit multiple points in the DCM pathway all at once.
So the clinical mandate from the guidelines is now crystal clear. What is the action item?
The mandate is that SGLT2I use is advised in patients with type 2 DM and established CVD, and even more strongly in those with established heart failure or CKD. And this is the key part. Irrespective of the baseline HbA1c target.
So even if their sugar is well controlled?
Even if their A1c is 6.8. If they have cardiorenal risk, they need this protection. Failure to initiate an SGLT2I in this population now constitutes suboptimal care.
Okay, now let's pivot to the other essential class, the GLP-1 receptor agonists, liraglutide, semaglutide. If the SGLT2s handle the pump failure, what's the primary domain for the GLP-1s?
Their primary benefit lies definitively in reducing major adverse cardiovascular events.
Wait.
MACE.
The atherosclerotic events.
The plumbing problems. Non-fatal MI, non-fatal stroke, and CV death. Pooled meta-analysis of trials like LEADER and SUSTAIN-6 shows a consistent MACE reduction with a pooled hazard ratio of 0.88.
A 12% risk reduction.
12% relative risk reduction, yes. And they show significant reductions specifically in CV death and, perhaps most powerfully, in stroke.
Which suggests their mechanism is really centered on the atherosclerotic process itself.
Exactly. Improving endothelial function, stabilizing plaques, reducing inflammation. They address the fundamental atherosclerotic engine.
Let's reinforce this distinction. SGLT2s excel at preventing pump failure HHF, driven by DCM. GLP-1s excel at preventing the plumbing crisis MACE and stroke, driven by atherosclerosis.
That is the single most important clinical concept we've covered. It's also important to note that GLP-1s generally show neutral effects on HF hospitalization, which really highlights the difference in their primary action.
So their clinical mandate is a bit different. Where do you reach for a GLP-1?
They're preferred agents for ANG-TE reduction, especially in patients with established CVD, like a history of MI or stroke, or those with multiple risk factors but maybe no overt HF or CKD.
So the choice often comes down to the patient's highest immediate threat.
Precisely. If it's heart failure or CKD, SGLT2I is mandatory. If it's a history of stroke or MI, a GLP-1 is the immediate choice. And in many very high-risk patients, you'll end up using both for dual protection.
This has effectively killed the simple sequential treatment algorithm we learned in med school. It's not metformin, then a sulfonylurea, then something else.
That script is gone. It's metformin plus an immediate upfront assessment of cardiorenal risk, followed instantly by the appropriate CV protective agent, regardless of whether the patient's A1C is 6.8 or 8.5. We are treating the predicted complication proactively.
So while these new agents are a revolution, we can't just ignore the legacy aspects of diabetes care. Comprehensive risk factor modification, blood sugar, blood pressure, lipids, that's still the indispensable pillar.
Absolutely.
But we need to discuss how the intensity of these targets has been refined. And this is where, that Brené Brown lens is vital. We're dealing with people, and these decisions require trust and honest communication about trade-offs.
That's right. Let's start with glycemic control. The history of this target is complex and a bit contradictory.
The early landmark trials, UKPDS and DCCT, proved that early intensive glycemic control is fantastic for microvascular risk.
Retinopathy, nephropathy, neuropathy, no question.
But when we try to replicate that intensity later in the disease in patients with long-standing diabetes and established CVD, things went sideways.
They certainly did. Trials like ACCORD and VADT, the finding was startling. Intensive control showed no significant short-term CV benefit, And worse, the Accord trial was stopped early in the intensive arm because of an unexpected signal of increased mortality.
And that was primarily attributed to severe, frequent hypoglycemia, right?
Yes. In the pursuit of an A1C near 6.0, clinicians were driving patients, particularly elderly patients with lots of comorbidities, into dangerous low glucose states. It was a painful but critical lesson. In high-risk patients, the immediate harm from hypoglycemia outweighs any speculative short-term benefit.
So tight control is great early on, but potentially dangerous later.
It's a nuanced picture, and we have to integrate the power of the legacy effect.
Metabolic memory.
Metabolic memory. The UK PDS follow-up showed that those patients treated aggressively early did show CV risk reduction decades later, even after their control worsened.
So we can't give up on good control, but the intensity must be tailored. This leads to individualized goals. What does that look like in the clinic today?
It means we've moved past the one-size-fits-all A1C of 7.0. The ADA and ESD guidelines strongly endorse individualized targets.
So walk us through the high-risk end of that spectrum. Who is a candidate for a less stringent target?
A target of 8% or even higher may be appropriate and safer for patients with moderate to severe CVD, a limited life expectancy, advanced complications, or, most importantly, a history of severe hypoglycemia.
Those patients' safety and quality of life trump marginal risk reduction.
Absolutely. Stringent targets less than 6.5 or 7.0 are reserved for younger, healthier, newly diagnosed patients. This requires a real partnership with the patient.
Okay, moving to hypertension management. This is arguably the single biggest modifiable factor in these patients.
It is absolutely crucial. Hypertension accelerates every major complication far more aggressively in diabetes. The UK PDS showed that lowering blood pressure had a greater benefit on DM-related death and stroke than glycemic control did. You get more bang for your buck hitting BP targets.
What's the target now?
The goal should be less than 130/80 in most patients, especially those with high ASCVD risk, or CKD. It's a bit less aggressive than some older guidelines, reflecting that pushing below 120 gives diminishing returns with more side effects.
And in terms of drug choice?
ACE inhibitors, or ARBs, are the cornerstone. While the CV risk reduction is mostly about the degree of BP lowering, these agents offer critical independent kidney protection, especially if there's albuminuria.
And let's just reiterate that warning about combining them.
A high-yield point. Avoid combining ACE inhibitors and ARBs. Dual blockade increases the risk of hyperkalemia and acute kidney injury with no incremental cardiovascular benefit.
Finally, lipid management. What is the statin mandate for this population?
Statins are foundation therapy. They are recommended for all DM patients aged 40 to 75, regardless of their estimated baseline ASCVD risk. Moderate intensity is the starting point.
But for those who already have ASCVD, we get much more aggressive.
Much more. Patients with established ASCVD need high-intensity statins to get an LDL reduction of 50% or more. The European guidelines are even more aggressive for the very highest risk patients, pushing for an LDL target of less than 55.
That often requires more than just a statin.
Yes, often adding ezetimibe or a PCSK9 inhibitor. But critically, we have to remember, the benefits of massive CV event reduction with statins overwhelmingly exceed the small risk of statin-induced diabetes. The CV protection is the priority.
Okay, we spend a lot of time on the heart and kidneys, but we have to maintain that holistic view. Diabetes is a systemic, whole-body disease of the arteries and nerves. This is about integrating those high-yield clinical correlations, the things we need to be looking for on every clinical round.
And we have to remember that diabetes doesn't just accelerate disease. It changes the distribution of atherosclerosis. It tends to hit the smaller, more distal vessels.
Let's ground this in some AMBES-style clinical examples. Let's start with diffuse disease of the aortic bifurcation-Leriche syndrome.
Right. This is a diagnosis of high aortoiliac occlusive disease. The classic clinical triad is something every clinician should just have locked in their brain.
What are the three features?
First, buttock, hip, or thigh claudication. Thigh location is key. Second, erectile dysfunction, which is nearly ubiquitous. And third, absent or severely diminished femoral pulses bilaterally.
So a diabetic patient with atypical leg pain that gets better with rest, plus new ED, you have to be thinking about this.
You have to. Check the femoral pulses, get an ABI immediately. The second scenario is subclavian steal syndrome. This diagnosis often requires a really high degree of suspicion.
Describe that presentation.
It's a patient with all the risk factors, DM, hypertension, who gets symptoms of upper extremity ischemia, heaviness, fatigue, maybe a cooler arm. But critically, They also get neurological symptoms, dizziness, presyncope. They're specifically related to arm exertion.
It's a literal steal of blood from the brain.
Exactly. An atherosclerotic plaque blocks the proximal subclavian artery. When they use that arm, blood gets drawn backward down the vertebral artery, stealing it from the brainstem. You have to check blood pressures in both arms. A difference of more than 20 millimeters of mercury is highly suggestive.
So these cases just reinforce that diabetes creates this hyper-accelerated dysfunctional arterial environment everywhere.
And finally, we have to return to neuropathy. Specifically, the distinction that prevents amputations, differentiating the cause of foot ulcers.
The painful versus the painless ulcer.
Exactly. The painless foot ulcer is the hallmark of diabetic peripheral neuropathy, or DSPN. It's from loss of protective sensation, LOPS. The patient gets repeated trauma and doesn't feel it. These ulcers are pressure points, and pulses are often palpable.
Whereas an ulcer that causes intense, excruciating pain suggests.
That suggests an arterial ulcer. Ischemic in origin. These are smaller, punched out, and occur distally on the toes. The skin is cold and pale, pulses are absent. The pain is severe because the tissue is actively dying.
And the monofilament test is still the best screening tool.
The fastest, most effective screening tool for LOPS in every annual foot exam. And we have to remember that autonomic neuropathy affects systems beyond the heart. Gastroparesis, causing bloating and erratic glucose control. Diabetic cystopathy, leading to urinary retention. And erectile dysfunction, which is often one of the earliest markers of pervasive vascular and nerve damage.
It's a strong harbinger of what's to come.
It is. The clinical takeaway for daily rounds is to think systemically. When you have a diabetic patient with atypical symptoms, you have to proactively assess pulses, do an ABI, and do the monofilament test. The pathology is never siloed. We began this deep dive by asking how diabetes fundamentally changes cardiac management. The practice shift is not incremental. It is radical.
It has to be.
The evidence demands we change our foundational priorities. We have to shift permanently from viewing glucose control as the primary therapeutic goal to seeing SGLT2 inhibitors and GLP-1 RAs as essential foundation therapies for cardiorenal protection.
Irrespective of the A1C.
Irrespective of the A1C number. We're now mandated to treat the failing organ systems, the heart and the kidney first, not just the sugar level.
Let's consolidate the 4 crucial, practice-changing insights that everyone listening needs to internalize and implement tomorrow.
First, diabetes is a primary independent cardiac risk factor for HFpEF. This is driven by diabetic cardiomyopathy, metabolic inflexibility, ceramide toxicity, and AG-driven fibrosis. We have to screen for and treat diastolic dysfunction.
Second,
SGLT2 inhibitor therapy is now a standard of care for cardiorenal risk reduction. Its defining benefit is preventing heart failure hospitalization. If your patient has cardiorenal risk, they need an SGLT2I.
Third, GLP-1 receptor agonist therapy is crucial for reducing atherosclerotic events, MAC, MI, and stroke. Using these 2 classes together allows us to provide targeted protection against both the cloning crisis and the pump failure.
And finally, while early intensive glycemic control provides that powerful legacy effect, treatment goals must be individualized. Less stringent goals, an A1C of 8% or higher, are appropriate and safer for elderly patients or those with high CV risk. Prioritize risk mitigation over tight glucose metrics.
That is the definitive cultural and clinical shift.
It is.
Okay, so the data confirms that diabetes creates this state of systemic inflammation driven by AGEs, oxidative stress, all of it. If chronic, widespread inflammation is truly the foundational driver of all these complications. Here's a final provocative thought for you to consider. How might the next generation of therapies focus on precise, targeted inflammation modulation? Directly inhibiting specific pro-inflammatory pathways rather than just using hemodynamic or broad metabolic targets to achieve even greater cardiorenal outcomes. If inflammation is the true root cause, the eventual therapeutic solution has to align with that deeper target.
That is the necessary horizon for truly preventative cardiometabolic medicine.
Thank you for joining this deep dive. We encourage you to review the source data, synthesize the pathophysiology, and apply these evidence-based, practice-changing insights immediately in your clinical routines.